Thank you, Beth, for the introduction. Before I begin, I just want to congratulate Beth and Antoinette, Dr. Sharma, Dr. Kinney on the 20th anniversary of the Nurse Tech Symposium. This is a great thing that we can share our knowledge with the nurses and the techs in this field. Today I'm here to talk to you about management updates in peripheral vascular disease for 2017. I don't have any disclosures, but I'm thinking of joining Dr. Kapoor's group. So basically, to review, what is peripheral artery disease? Peripheral artery disease is an obstruction of blood flow to non-coronary and extracranial arteries, most commonly caused by atherosclerosis, which affects 8 to 12 million Americans. Not so surprisingly, 40 to 60% of patients with PAD also tend to have CAD and/or cerebral vascular disease. The prevalence of PAD was found to increase with age, as Dr. Kapoor showed us earlier, in both men and women, with onset of symptoms typically in their 50s. Interestingly enough, women were found to have more functional impairment than men, and African Americans were also twice as likely to have PAD when compared to Caucasians. These are some studies that looked at the prevalence of PAD, but it was the Partners trial in 2001, which was a while ago, but it really identified that those individuals that have a history of smoking and diabetes really put them at risk for PAD. In fact, 1 in 3. The key risk factors for peripheral artery disease is very similar to coronary artery disease. As we know, it's diabetes, hypertension, cigarette smoking, high cholesterol, advanced age, non-white ethnicity, and increased inflammatory markers like C-reactive protein. More specifically, when we look at individuals that are at risk for lower extremity PAD, they include all those same patients, but we also look for patients that present with symptomatic leg pain when they walk, or as we call it, intermittent claudication. Also those patients that come with ischemic rest pain or non-healing ulcers that have failed medical therapy. We tend to find them at higher risk for PAD. Lastly, individuals with abnormal peripheral pulses on examination, those with known CAD, carotid stenosis, renal stenosis, we find them at risk as well. But knowing all this, what do we do to screen patients for peripheral artery disease? We either send them for non-invasive studies like ABI, PVRs, arterial duplexes, or if they're really high risk, we just send them directly to the cath lab for peripheral angiogram. Now, as we see, diabetes is one of the most significant risk factors for developing peripheral artery disease. When we think about diabetics, we think about this rule of 15, which basically says that 15% of diabetic patients will have a foot ulcer in their lifetime. Of those patients that get a foot ulcer, 15% will lead to osteomyelitis. And of those patients that get osteomyelitis, 15% will lead to an amputation. Now, once we get to amputations, now we think about the rule of 50. Half the patients that get amputations are at the transfemoral, transtibial level. 50% of those patients will have a second amputation in 5 years. And 50% of those patients that get a second amputation, they won't survive another 5 years. So in brief, we can see how devastating untreated or poorly managed peripheral artery disease can affect an individual, reducing their quality of life with their either intermittent claudication symptoms or non-healing ulcer, enduring limb loss, and potentially premature mortality. So as nurses and techs in the cath lab, what do we do to fix this? I mean, this is something that we need to treat. So we have many tools, luckily. Our original mainstay of therapy was balloon angioplasty, or percutaneous transluminal angioplasty, or as we all call it, PTA. It was the gold standard of treating PAD with it's a very simple procedure for interventionalists and with a very good success rate. However, as we see, the patency rates for just PTA is relatively low after 12 months, to be around like 60%. Stenting became an advancement to PTA, which was found generally easy to do with a 95% success rate, and had improved restenosis rates over PTA alone. This is some graphs from the New England Journal of Medicine, which illustrates the reduction of restenosis rates when comparing PTA alone to stenting, which is in the green. You can see on the graph on the bottom, that the reduction of restenosis rate on arterial duplex was lower than just angioplasty alone at 3 months, 6 months, and 12 months. More importantly for our patients, their function, you can see that their 6-minute walk test had improved, as well as their ankle brachial index, thus showing that there's an improved quality of life. The two stents that we use here at Mount Sinai are the Supera and the Zilver stent. They're both self-extending stents made out of nitinol, and they're used to treat stenotic femoral popliteal stenosis. The Supera stent is a bare metal stent, which tends to be very flexible, and we'd like to put it in places that are inflection points, like the popliteal or the proximal SFA. The Zilver PTX is a drug-coated stent, which doesn't actually elute any drug like drug-eluting stents do in coronaries, but rather the nitinol is coated with the drug, and there's no polymer. In addition to PTA and stenting, there are several ways we can go after treating more significant atherosclerotic or calcified plaques. We can use directional, orbital, rotational, laser, and hybrid atherectomy. And I have some videos just to show you guys how these devices work. This is a first device. It's called the Hawk One. It's made by Covidien, and it's a directional atherectomy device that works with a carbide cutter that spins at a very high rate of speed to excise plaque from the artery. As the plaque is excised, it's stored in the nose cone. We call this directional atherectomy because it only cuts in a single plane, and in order for the operator to do a full 360-degree circle, they need to pull back, rotate the device, and then do multiple passes. This is an image of the excised plaques from the Hawk One device. They kind of look like worms. The white is actually good. It's the atherosclerotic or the calcified plaques. However, when we start to see red, we know that we're making some subintimal cuts into the vessel wall. Another one of the newer devices is Orbital Atherectomy. This is made by CSI, but basically works by having a crown that rotates in a jump rope-like fashion in calcified vessels when it sands down all the calcified atherosclerosis. Here you can see there's like two modes. One is a slower that kind of makes it a small lumen, and then the higher speed really gets to shaving away all that calcium so that we can prep the vessels for either stenting or drug-coated balloon. Now, before we had drug-coated balloon, we were doing a lot of stenting, and as we know, stents do develop some restenosis. So Spectranetics had developed the Turbo Elite catheter, which is an excimer laser that is FDA approved to debulk the neomintimal hyperplasia, which develops in stent restenosis. Last but not least is Boston Scientific's Jetstream. It's rotational atherectomy with active aspiration, and the idea behind it is that it minimizes the risk of distal embolization. So if you want to think of angiojet and rota for the coronary people, that's essentially how it works. Now, going back to the newest technology, what Dr. Kapoor was talking about earlier was drug-coated balloons. This is our newest toy in the toolbox to treat peripheral artery disease. It's not that new, as we know. It's been with us in the US for about 3 years and even longer in Europe. But more and more studies are showing DCB to have a significantly game-changing data. Drug-coated balloons work by interfering the Restenotic Cascade. The Restenotic Cascade is basically the body's way of healing itself. It's like a scab when you get a cut. Essentially, when our interventionalists do a PTA, they create a controlled injury to the vessel in which the body elicits an inflammatory response, which eventually, in time, will cause restenosis in the weeks to months following a PTA. Drug-coated balloons were found successful as paclitaxel, it's the medication on all the first-generation balloons, works as an anti-proliferative agent, which works by breaking up the restenotic cascade, therefore reducing inflammation and inhibiting smooth muscle cell migration. Paclitaxel retention is essential for this to work. Here we could see that the vessel wall, the layers of the vessel wall. Now, paclitaxel works to interfere with that smooth muscle cell growth during the healing phase, which typically typically occurs around 14 days after the procedure, thus preventing restenosis. Now, there are various companies that make drug-coated balloons. The two balloons that we use here at Mount Sinai are the Lutonics and Impact Balloon, which are both FDA approved for treating femoral popliteal lesions. Now, drug-coated balloons are made up of several different factors. The main ones are the coating process is how the drug is placed on the balloon. We want it to be uniform and consistent. They do it either by dipping or spraying. The excipient, which I'll talk more about later, it facilitates really the transfer of the drug to the vessel wall. The anti-restenotic drug, which is paclitaxel on all these first-generation devices, and simply the balloon platform. Can we get this drug to the target lesion? Factors that influence drug-coated balloon performance is durability. Can the drug stick to the balloon as it travels? Deliverability, can the balloon make it there? And uptake, how long the drug can sit on the vessel so that we can be covered during that 14-day period to have an anti-proliferative effect. Now, talking about the excipients, there was a SCAR registry in Sweden which looked at the role of excipients on drug-coated balloons in PCI, in coronaries. That registry looked at two different paclitaxel drug-coated balloons in PCI. One arm was treated with a drug-coated balloon that only had paclitaxel, whereas the other arm used paclitaxel with an excipient. That registry showed that excipients had a lower rate of restenosis after 12 to 18 months, thus showing that having an excipient does play a role in these drug-coated balloons. The Lutonics balloon uses polysorbate and sorbitol as their excipient, while the Impact balloon uses urea. As Dr. Kapoor mentioned earlier, there's no class effect with drug-coated balloons. This is some of the 12-month data for both Lutonics and Impact. Lutonics had a 74% patency rate, and Impact was almost 90% patency rate after 1 year, both of which are significantly better than PTA alone, which is about 60%. And the beautiful thing is we're not leaving any metal in the body. The latest data from the Impact SFA trial, which was presented last year at Viva, shows that there was an almost 25% increased patency rate when using the Impact balloon when compared to just PTA alone after 36 months. Our clinical outcomes is the functional outcome for the patient is the 6-minute walk test, and we can see that the patients did walk, had very similar functional outcome in the 6-minute walk test than with the PTA group. However, they did it with 48% less reinterventions. So to summarize that Impact SFA trial summary, the Impact drug-coated balloon was found to be a very safe device with very good 3-year patency rates with low need for repeat reinterventions. Also, this data almost supports that the move to a drug-coated balloon to being first-line treatment for symptomatic PAD. Now, we know that there are some barriers to drug-coated balloons and treating PAD, and one of the things that we consider is calcium. Calcium does get in the way for the drug to be uptake into the vessel wall. So one of the important things we need to consider is vessel preparation, whether it's doing atherectomy in these calcified or severely stenosed lesions so that the paclitaxel can make it to the vessel wall. Otherwise, if we're not doing any vessel prep, it's like sprinkling salt on a rock. It'll just blow away and we won't get any benefit of the paclitaxel. So this graph above shows the correlation of the severity of calcification with primary patency rates and late luminal loss. We see that more severely calcified lesions result in lower patency rates and more late luminal loss after 12 months, which further supports the need for vessel preparation prior to drug-coated ballooning or stenting. Also, lesion length is something that interventionalists consider when they see a blockage. It was found that increased lesion length was an independent predictor of decreased patency alone, so the severity of PAD also needs to be considered when, before tackling interventions. So the future for the drug-coated balloon is whether this can be done safely and below the knee. Right now, drug-coated balloons are FDA approved for femoral popliteal lesions, and there are some studies that are starting to look at whether it can be used below the knee. One study was the Amphion Deep study from Impact, which was actually recalled in December 2013 because it did not meet primary effectiveness endpoints, and it had a higher rate of amputations, surprisingly. There's a couple more, there's a lot of other studies, two of them which I'll mention today is the Levant below the knee study, which is ongoing and currently enrolling patients, and the BEST CLI study, which is also ongoing and enrolling patients. Finally, some case photos and a quick case in the end if you have some time. If you look at this picture, if you look from the outside of the slide into the middle, the outside of the slide is baseline and the middle is the 6-month follow-up. On the left, you'll see a lesion that's treated with an impact DCB. If you look at the baseline over here, and then it's treatment with DCB and it's 6-month follow-up. Whereas another lesion which was treated with just standard PTA alone, this is the baseline lesion, which is very similar, and then the post-PTA in 6 months, you can see that the patency of the DCB is superior. Now, looking at this picture from left to right, you also see 2 SFA lesions. The lesion on the left is the one treated with PTA, and the one on the right was with DCB. As you look at the 6-month follow-up, you can see restenosis in the PTA treated lesion in the SFA, whereas the DCB is widely patent. One more picture. This is a CTO of the mid to distal SFA, which was treated with multiple drug-coated balloons. This is our immediate result, and the result 6 months post. And finally, this is an angio that shows the jet stream catheter, which is that rotational atherectomy. We see a severely calcified common femoral artery. This is typically where interventionalists park to do coronary cases or peripheral cases. So this is something we're going to consider when we're doing this intervention. So basically what we did is we crossed the lesion with the wire and we passed the filter below. Mount Sinai, they almost use filters for all these tough lesions so that there's no distal embolization. And they use the jet stream catheter, which is the rotational atherectomy with active aspiration. Finally, we ballooned it. And we had a nice angiographic result with a small non-flow limiting dissection. This is a paper that was written by Dr. Christian, which talked about drug-coated balloons and long femoral lesions. For those that don't know Dr. Christian or didn't come to the peripheral intervention, that's not Dr. Christian, that's one of his fellows. So in summary, management update for peripheral vascular disease in 2017, we know it's a significant disease process. It affects many people, has a very strong correlation with CAD. It's a progressively worsening disease and it has very poor outcomes if left untreated. We have many ways to treat peripheral vascular disease, which I went over today: balloon angioplasty, stenting, atherectomy, which is crucial to do vessel prep for either drug-coated balloon and stenting. And finally, the latest and best thing that it shows from the data is drug-coated balloon, which has, as we see in the IMPACT trial, has the best patency rates after 36 months with less need for repeat interventions and improved quality of life. So the hospital's happy, the patient's happy. Thank you very much.